Hello everyone, this is Dr. Sam and this video is about liver ultrasound reporting. We will see how to write ultrasound reports of liver pathologies. These will include clinical indication, findings and impression. The first case is of a simple hepatic cyst. A hepatic cyst may cause abdominal pain, and in some cases it can be asymptomatic and found incidentally. The clinical indication is abdominal pain in this example. This is the finding. The liver is normal in size and shape. A well-defined anechoic lesion with smooth borders and posterior enhancement measuring 2.5 centimeters in diameter is identified in the right hepatic lobe, consistent with a simple hepatic cyst. There are no internal septations, debris or calcifications. The intrahepatic and extrahepatic bile ducts are not dilated. We are only focusing on liver pathologies, so the findings and impressions are just related to the liver. It is not a complete abdominal ultrasound report. This is the impression. Mention that the findings are consistent with a simple hepatic cyst. Also mention the size of the cyst. If there are no other abnormalities seen, you can write no other significant abnormalities are identified, and you must write clinical correlation is recommended because a diagnosis is not completely done on ultrasound only. This is a case of hydatid cyst. The clinical indication in this case is abdominal pain and history of hydatid disease. These are the findings in this example. The liver is enlarged and has multiple cystic lesions identified in the right lobe. One of the cysts has a size of 5.5 into 5.2 centimeters and shows a well-defined wall, and a daughter cyst with internal septations. Such findings are consistent with a hydatid cyst. If there are multiple cysts, you can write the other cystic lesions range in size from 1 centimeter to 3 centimeters and appear to be simple cysts, and the bile ducts are normal. This is the impression. Findings are consistent with hepatic hydatid disease with a 5.5 into 5.2 centimeter hepatic hydatid cyst in the right lobe. If there are multiple cysts, you can mention them as well. And finally, you write clinical correlation is recommended to determine the appropriate treatment, which may include medical management, percutaneous drainage, or surgical intervention. Long-term follow-up is necessary to monitor for recurrence or complications. Now we will see calcified hydatid cyst. The clinical indication is a routine abdominal ultrasound. In the findings, mention the liver size and shape and a calcified lesion with irregular borders and posterior acoustic shadowing. Then measure the size of the lesion and in which lobe it is found. Usually no daughter cysts or internal septations are seen in a calcified hydatid cyst. And after these lines, you can mention the status of intrahepatic and extrahepatic bile ducts. In the impression, you can write the findings and the size of the lesion and its location. Also mention that there is absence of daughter cysts or internal septations, which suggests that the cyst is no longer active. After these lines, you can write the clinical correlation. Now we will look at a grade 1 fatty liver or steatosis. The clinical indication can be elevated liver enzymes, abnormal liver function tests, or no indication as it is seen routinely. In the findings, you can write the liver appears diffusely echogenic with increased echogenicity, consistent with grade 1 fatty liver. If there is no other abnormality found, you can write this line. And then you can write about the bile ducts and the gallbladder. You can write the increased echogenicity of the liver in the impression. And then you can write about other lesions if they are seen. And finally, you can write the line about clinical correlation. Next, we move on to grade 2 steatosis. The indication is elevated liver enzymes and abnormal liver function tests. In the findings for grade 2 steatosis, you can write the liver appears diffusely echogenic with obscured periportal echogenicity and partially obscured diaphragm, consistent with grade 2 fatty liver. In the impression, you can mention grade 2 hepatic steatosis, and finally you can mention the clinical correlation. These are the findings of a grade 3 fatty liver. There will be obscured periportal echogenicity as well as obscured diaphragmatic echogenicity consistent with grade 3 fatty liver. You can write findings are consistent with grade 3 fatty liver and mention the severe increase in echogenicity. In most cases, mild ascites is also present. And then you can write about clinical correlation. A patient with hepatic abscess can present with abdominal pain and fever. In the findings, you can write a hypoechoic and heterogeneous lesion and mention its location and the size, and mention the presence of internal echoes and no internal vascularity, as an abscess will not have any internal vascularity. On color Doppler, these findings are consistent with hepatic abscess. Similarly, in the impression, you can write findings are consistent with hepatic abscess and write the size of the abscess followed by its location, and then you can write about clinical correlation. A hemangioma is usually an incidental finding on ultrasound. Usually the clinical indication is routine abdominal ultrasound. The liver is usually normal in size and shape. A well-defined hyperechoic lesion with smooth borders is seen. Such hyperechoic masses are consistent with a liver hemangioma. Liver hemangiomas are usually benign unless they cause symptoms or grow larger than 5 centimeters. Mention the size of the lesion and its location, followed by the line of clinical correlation. Clinical indication for focal nodular hyperplasia can be abdominal pain and incidental liver mass on prior imaging. It has variable appearances, usually a well-defined hypoechoic lesion with central echogenic scar is seen, and it has a spoke wheel vasculature on color Doppler. So you can write these features in the findings as well as the size and location of the mass. In the impression you can write a well-defined hypoechoic lesion with central echogenic scar. Then you can write its size, the spoke wheel vasculature, and the location in the liver. For hepatic adenoma, the clinical indication can be abdominal pain and elevated liver enzymes. It is often seen in patients with oral contraceptive use or anabolic steroid use. This tumor also has variable appearances. In this case, a well-defined hypoechoic lesion with irregular borders is seen. You just have to mention these features and write its size and location in the findings. In the impression, we can write these findings, but we cannot confirm an adenoma just on ultrasound, so we do not write adenoma in the impression. We just write the findings and advise further testing and clinical correlation. For hepatocellular carcinoma, the clinical indications include elevated liver enzymes, history of cirrhosis or hepatitis C. Its findings include a hypoechoic mass with irregular borders and internal vascularity on color Doppler. These findings are suspicious for hepatocellular carcinoma. In this example, cirrhosis was also present, so it is mentioned in the impression, and the suspicious mass and its features are also mentioned. Clinical correlation is recommended to determine the need for further evaluation or management. Now we will look at liver metastasis. The clinical indication in this case was a known history of colon cancer and abdominal pain. In the findings, you can mention the heterogeneous echotexture of the liver, multiple hypoechoic nodules, their sizes and their distribution throughout the liver. Such findings, along with a history of colon cancer, are consistent with liver metastasis. You can write the size of the largest lesion seen, and if other abnormalities are seen, you can also mention them as well. In the impression, you can write the findings are consistent with multiple liver metastasis, and you can also mention the primary cancer, which was colon cancer in this case, and then you can mention further evaluation and clinical correlation. This is a case of cirrhosis. The clinical indication can be elevated liver enzymes or alcohol use disorder. The findings will include the nodular appearance and coarse echotexture, which is consistent with cirrhosis. You can mention the liver size and also mention the size and appearance of portal vein. Then you can mention ascites. Write the amount of fluid seen. Usually ascites is present with liver cirrhosis. Then you can write about the spleen. Usually in liver cirrhosis, the spleen is enlarged. So you can write the size of the spleen and mention splenomegaly. In the impression, you can write about cirrhosis, ascites, splenomegaly, and portal hypertension. These features are usually seen in liver cirrhosis. And then you can write about clinical correlation. Now we will look at portal hypertension. It is usually associated with liver cirrhosis or chronic liver disease. So you can mention the liver's appearance, and also you can write about the appearances of inferior vena cava and hepatic veins. Usually the portal vein will be dilated, as in this example it is 14 millimeters or 1.4 centimeters in diameter and shows a reduced flow velocity of 18 centimeters per second, indicative of portal hypertension. And then you can write about the portal vein bifurcation as well as its intrahepatic branches. In the impression, you can write that the findings are consistent with portal hypertension and its association with chronic liver disease. After that, you can write about additional evaluation and management. For acute hepatitis, the clinical indications are usually abdominal pain and vomiting, jaundice, and elevated bilirubin levels. Typical findings of acute hepatitis is an enlarged liver, which may have a hypoechoic appearance. In this case, it is measuring 20 centimeters. Hepatitis also affects the gallbladder wall, so you can write a thickened gallbladder wall with pericholecystic edema. If other features are seen, you can also mention them in the findings, such as an enlarged spleen. In the impression, you can write that these findings are non-specific but suggestive of acute hepatitis, including hepatomegaly with slight hypoechoic appearance and an enlarged spleen. Then you can write about the thickened gallbladder wall with pericholecystic edema. Finally, you can write about further evaluation and clinical correlation. And this video is about gallbladder ultrasound reporting. We will look at gallbladder pathologies and see how to write reports for each pathology. This will include clinical indication, findings, and impression. We are only focusing on the gallbladder, so other organs reports will not be in this video. This is not a complete abdominal ultrasound report. The first case is cholelithiasis or gallstones. The clinical indication in this example is abdominal pain and bloating. In the findings, you can write the number of gallstones, whether it is single or multiple. The stone or stones are seen as echogenic structures. This is suggestive of cholelithiasis. Then you can write the measurement of the largest stone if there are multiple stones, and then you can write about gallbladder wall thickness. This is the impression for this example. Cholelithiasis with multiple gallbladder stones, including a 1.5 cm stone in diameter. Clinical correlation is recommended. Always add this line because diagnosis is not only done on ultrasound alone. Now we will look at West sign, which stands for wall echo shadow. It occurs when the gallbladder is completely filled with gallstones. In the findings, you can mention the thickened gallbladder wall and the multiple echogenic foci within the gallbladder. That will be consistent with cholelithiasis. Then you can mention a well-defined curvilinear echogenic structure along the wall of the gallbladder with a corresponding acoustic shadow consistent with West sign. In the impression, you can write cholelithiasis with multiple stones and the presence of the West sign. Clinical correlation is recommended. For gallbladder sludge, the clinical indication can be abdominal pain and nausea or follow-up of cholecystitis. In the findings, you can write about the distended gallbladder, the thickened wall, and what it contains, as sludge appears echogenic with layering dependent to gravity, that is consistent with gallbladder sludge. In the impression, you can write gallbladder sludge with thickened gallbladder wall. If there are no gallstones or biliary obstruction, you can write this line, and then you can write clinical correlation is recommended. Now we will look at acute cholecystitis. The clinical indication can be right upper quadrant pain, fever, elevated liver function tests. In the findings, you can write about the distended gallbladder with wall thickening and the measurement of the wall. Then you can mention the presence of pericholecystic fluid. If there is sludge or gallstones, you can write about that. In the impression, you can write findings are consistent with acute cholecystitis, and then you can mention the presence of sludge or gallstones, and then you can write about pericholecystic fluid. You must write correlate with clinical and laboratory findings, and then you can write this line about medical management. The clinical indications for gangrenous cholecystitis can be right upper quadrant pain, fever, or leukocytosis. In the findings, you can write about the distension of gallbladder and its thickened walls with no clear interface between the outer edge of the gallbladder and the liver. Usually the walls are irregular, so you must mention that, and it will show signs of necrosis with areas of wall disruption and ulceration. The gallbladder lumen contains echogenic bile and there are no visible gallstones. This is in regards to this case. In the impression, you can write findings are consistent with gangrenous cholecystitis. You must write urgent surgical intervention is recommended. because this is an emergency case. For gallbladder perforation, the indications can be abdominal pain and fever. In the findings, you can write about the distended gallbladder and its thickened walls, and mention the pericholecystic fluid. If there is echogenic material in the lumen, you can also mention that. Then you must mention the disruption of the wall and the location of the disruption. In this case, it was the body of the gallbladder. And then you must write the presence of fluid in the surrounding area. If fluid is seen outside the disruption. In the impression, you can mention gallbladder perforation with pericholecystic fluid and debris. The disruption is seen at the body. And finally, you must write urgent surgical intervention is recommended. For gallbladder polyp, the indication can be abdominal pain. Usually the gallbladder is normal in size and shape. You can write this line, and after that you can mention a polypoid lesion is noted in the gallbladder lumen, and then you can write its size. Usually the polypoid mass is echogenic, so you can write this. And these masses have a smooth surface and appear to be arising from the gallbladder wall. No shadowing or enhancement is noted posterior to the lesion because it is a solid lesion without calcifications. And then you can write about the gallbladder wall thickness. In the impression, you can write a polypoid lesion and its size, and then you can write features consistent with a gallbladder polyp, and finally you can write about clinical correlation. Here is a case of adenomyomatosis. The clinical indication is abdominal pain. In the findings, you can write about the distended gallbladder with thickened walls and containing multiple echogenic foci with comet tail artifacts consistent with adenomyomatosis. And then you can write about gallstones, or if there is any pericholecystic fluid. For this case, the impression was gallbladder adenomyomatosis with comet tail artifacts without evidence of cholelithiasis. Now we will look at gallbladder cancer. The clinical indication here is suspicion of gallbladder cancer. In the findings, you can write a large mass occupying the gallbladder lumen. The mass appears heterogeneous and has irregular borders. And then you can write about gallstones or sludge. In the impression, you can write the findings are highly suggestive of gallbladder cancer, and further evaluation with CT or MRI is recommended. You can write these statements in the impression. This is a case of porcelain gallbladder. The indication was right upper quadrant pain. In the findings, you can write a thickened, echogenic and irregular wall with focal calcification. These can be the findings for porcelain gallbladder. This is the impression. You can write porcelain gallbladder with or without the evidence of a mass. And then you can write recommend correlation with clinical and laboratory findings and consideration for cholecystectomy given the risk of malignancy associated with this condition. And this video is about bile duct ultrasound reporting. You will learn how to write ultrasound reports related to bile duct pathologies. The main focus of the reports will be on bile ducts. The reports will include three parts: clinical history, findings, and impression. Our first report is of normal bile duct. This is the clinical history, evaluation for abdominal pain, no history of gallstones or liver disease. These are the findings. The liver is normal in size and echo texture. No focal liver lesions identified. The gallbladder is well distended with no evidence of gallstones or sludge. The gallbladder wall is not thickened. The common bile duct measures 4 mm in diameter, which is within normal limits. No dilatation or obstruction is noted. Intrahepatic ducts. No intrahepatic biliary dilatation is seen. The pancreas is visualized and is normal in appearance. Both kidneys appear normal. Vascular structures. The portal vein and hepatic arteries are normal. Here is the impression. Normal ultrasound examination. No evidence of gallstones, cholecystitis, or bile duct obstruction. Now we move on to pathologies. This report is of fusiform dilation, clinical history, evaluation for recurrent abdominal pain, and jaundice. Here are the findings. The liver and gallbladder are normal. Common bile duct. There is fusiform dilation of the common bile duct measuring approximately 15 mm in diameter. The dilated duct has a smooth contour without evidence of intraluminal stones or strictures. This finding is consistent with a choledochal cyst, likely type 1. Intrahepatic ducts. Mild intrahepatic biliary dilatation is noted, likely secondary to the choledochal cyst. The pancreas, kidneys, and other abdominal organs are unremarkable. This is the impression. Sonographic findings suggestive of a choledochal cyst, most likely type 1, characterized by fusiform dilation of the common bile duct. Correlation with clinical findings and further investigation with MRI or MRCP may be beneficial for comprehensive evaluation and management planning. Now we have a report of dilated common bile duct, clinical history, evaluation for upper abdominal pain, and jaundice. These are the findings. The liver is normal and the gallbladder is distended, but no gallstones or sludge are observed. The gallbladder wall is not thickened. The common bile duct is dilated, measuring approximately 10 mm in diameter. There is no visible evidence of an obstructing stone at the level of the distal duct. Intrahepatic ducts. There is mild to moderate dilation of the intrahepatic bile ducts. The pancreas, kidneys, and vascular structures are all normal. This is the impression. The ultrasound findings demonstrate dilation of the common bile duct and mild intrahepatic ductal dilation. These findings could be indicative of biliary obstruction. Further evaluation with magnetic resonance cholangiopancreatography or endoscopic retrograde cholangiopancreatography is recommended to determine the cause of the obstruction and appropriate treatment. This is a report of Caroli disease, clinical history, chronic abdominal pain, and history of recurrent cholangitis. These are the findings. The liver is enlarged and shows abnormal echo texture. No discrete hepatic lesions are noted. The gallbladder is normal in size and contour. No evidence of cholelithiasis or cholecystitis. Intrahepatic ducts. There are multiple segmental dilations of the intrahepatic bile ducts, predominantly in the right lobe. These dilations appear saccular and are consistent with the central dot sign suggestive of Caroli disease. The common bile duct is not dilated and appears normal in course and caliber. The pancreas, kidneys, and other abdominal structures are all normal. This is the impression. The ultrasound findings are suggestive of Caroli disease, characterized by saccular dilations of the intrahepatic bile ducts, particularly in the right hepatic lobe. Clinical correlation and further diagnostic workup, including MRCP, are recommended for confirmation and assessment of disease extent. Now we have a report of intrahepatic biliary duct stones, clinical history, persistent upper abdominal pain, fever, and jaundice. The liver is normal in size with a slightly coarse echo texture. No focal hepatic lesions. The gallbladder appears contracted with thickened walls. No gallstones are seen in the gallbladder lumen. Intrahepatic ducts. There are multiple echogenic foci within the dilated intrahepatic biliary radicals, particularly in the right hepatic lobe. These foci exhibit posterior acoustic shadowing, suggestive of intrahepatic biliary duct stones. The common bile duct is mildly dilated, measuring approximately 8 mm in diameter. No stones are visualized within the common bile duct. The pancreas is obscured due to overlying bowel gas. No obvious pancreatic abnormality is detected. The kidneys are normal and there are no other abnormal findings. This is the impression. Ultrasound findings suggestive of intrahepatic biliary duct stones, primarily within the right hepatic lobe, with associated biliary radical dilation. Mild dilation of the common bile duct is also noted. Clinical correlation is recommended and further evaluation with ERCP or MRCP may be considered for confirmation and management planning. Now we have a report of common bile duct stone, clinical history, patient presenting with acute onset of upper abdominal pain, jaundice, and history of gallstones. The liver is normal in size with homogeneous echo texture. No focal liver lesions identified. The gallbladder contains echogenic material consistent with gallstones. There is no evidence of gallbladder wall thickening or pericholecystic fluid. The common bile duct is dilated, measuring approximately 9 mm in diameter. An echogenic focus with posterior acoustic shadowing is noted in the distal common bile duct, suggestive of a bile duct stone. Intrahepatic ducts. Mild intrahepatic biliary dilatation is observed, which may be secondary to the obstructing stone in the common bile duct. The pancreas and other abdominal structures were normal. This is the impression. The sonographic findings are suggestive of a common bile duct stone causing biliary duct dilatation. Given the clinical presentation, further evaluation with ERCP or MRCP is recommended for potential therapeutic intervention. Here is a report of Bile syndrome. Clinical history: patient presenting with jaundice, right upper quadrant pain, and history of gallstones. These are the findings. The liver is normal. The gallbladder contains multiple gallstones. One large stone is noted at the neck of the gallbladder or cystic duct, causing extrinsic compression on the adjacent common hepatic duct. The common hepatic duct appears dilated, proximal to the site of compression. The distal common bile duct is of normal caliber. No intraductal stones are visualized in the common bile duct. Intrahepatic ducts. Mild to moderate intrahepatic biliary dilatation is noted, more pronounced in the right lobe. The pancreas, kidneys, and other abdominal organs are normal. Here is the impression. The ultrasound findings are consistent with Bile syndrome, characterized by extrinsic compression of the common hepatic duct by a large gallstone at the gallbladder neck or cystic duct, resulting in biliary obstruction and dilatation. Further evaluation with MRCP or ERCP is recommended for a definitive diagnosis and to guide potential therapeutic interventions. Now we have a case of hemophilia. Clinical history: recent history of abdominal trauma, followed by upper abdominal pain, jaundice, and gastrointestinal bleeding. These are the findings. The liver is normal in size, with a slightly heterogeneous apotexture, likely related to recent trauma. No obvious hepatic lacerations or hematomas are identified. The gallbladder is well distended. There is echogenic material within the gallbladder lumen that shows layering, suggestive of blood clots. No gallstones are observed. The intrahepatic ducts are normal. The common bile duct appears slightly dilated, measuring approximately 8 mm. Echogenic material is noted within the duct, which could represent blood clots, indicative of hemophilia. The pancreas is obscured by bowel gas but appears unremarkable. The kidneys are normal, and there is no evidence of vascular injury or active bleeding. This is the impression. The sonographic findings suggest hemophilia, characterized by the presence of echogenic material within the gallbladder and common bile duct. likely secondary to recent abdominal trauma. The absence of other obvious sources of bleeding in the abdomen and the clinical history supports this diagnosis. Further evaluation with ERCP or angiography may be necessary for confirmation and to guide potential therapeutic interventions. This is a case of pneumobilia, which refers to air in the bile ducts. Clinical history: patient with a history of recent biliary surgery presenting with abdominal pain and fever. The liver is normal. The gallbladder is not visualized, consistent with patient's history of cholecystectomy. The gallbladder was removed. Intrahepatic ducts. There are bright echogenic linear and branching structures within the bile ducts with associated dirty acoustic shadowing, suggestive of air within the biliary tree, that is, pneumobilia. The common bile duct is not dilated and no intraluminal stones are observed. Echogenic foci consistent with air are noted within the duct. The pancreas, kidneys, and other abdominal organs are all normal. This is the impression. Ultrasound findings are indicative of pneumobilia, characterized by the presence of air within the biliary tree, likely secondary to recent biliary surgery. The absence of biliary dilatation or stones is noted. Clinical correlation is recommended and further evaluation with CT scan or MRCP may be beneficial for a more comprehensive assessment and to rule out any complications like biliary enteric anastomotic leak or infection. This report is of acute cholangitis, clinical history, patient presenting with fever, right upper quadrant abdominal pain, and jaundice. The liver is normal in size with a coarse echo texture. The gallbladder is distended with thickened walls measuring up to 5 mm. No gallstones are visualized within the lumen. Pericholecystic fluid is noted. Intrahepatic ducts. There is moderate dilation of the intrahepatic biliary radicals. The common bile duct is dilated, measuring approximately 10 mm in diameter. Echogenic debris is noted within the duct, suggestive of sludge or pus. The pancreas, kidneys, and other abdominal organs are all normal. And this is the impression. The sonographic findings are suggestive of acute cholangitis, evidenced by biliary ductal dilatation, thickened gallbladder wall with pericholecystic fluid, and echogenic material within the common bile duct, possibly representing sludge or pus. These findings warrant urgent clinical correlation and further evaluation, potentially including ERCP for both diagnostic and therapeutic purposes. Now we have a report of recurrent pyogenic cholangitis, clinical history, patient with a history of multiple episodes of cholangitis, presenting with fever, right upper quadrant pain, and jaundice. The liver shows irregular contours and heterogeneous echo texture, which may indicate chronic liver disease. Multiple hypoechoic areas suggesting abscesses are noted. The gallbladder appears contracted with thickened walls. No gallstones are visualized. Intrahepatic ducts. There is significant dilation of the intrahepatic bile ducts with irregularity in ductal caliber. Multiple echogenic foci, possibly representing biliary stones or sludge, are seen within the dilated ducts. The common bile duct is dilated, measuring approximately 11 mm in diameter. Echogenic debris, suggestive of pus or sludge, is present within the duct. The pancreas is difficult to visualize completely due to overlying bowel gas, but no obvious abnormalities are detected in the visualized portion. The kidneys and other abdominal organs are normal. This is the impression. The ultrasound findings are suggestive of recurrent pyogenic cholangitis, as evidenced by the irregular dilation of intrahepatic bile ducts with echogenic foci and debris, chronic liver changes, and dilated common bile duct with contents suggestive of infection. Clinical correlation and further diagnostic workup, possibly including MRCP or ERCP, are recommended to confirm the diagnosis and plan appropriate management. This report is of ascariasis. Clinical history: patient presenting with epigastric pain, jaundice, and a history of travel to an endemic area. These are the findings. The liver and gallbladder are normal. There is mild dilation of the intrahepatic bile ducts. The common bile duct is dilated, measuring approximately 10 mm in diameter. Within the duct, there are several tubular, non-shadowing echogenic structures that are moving with respiration and changing shape, highly suggestive of Ascaris lumbricoids worms. The pancreas, kidneys, and other organs are normal. Here is the impression. The sonographic findings are consistent with biliary ascariasis, evidenced by the presence of tubular echogenic structures within the dilated common bile duct, likely representing Ascaris lumbricoids. This diagnosis should be correlated clinically, and further management might include anthelmintic therapy and potentially ERCP or worm extraction. This is a report of HIV cholangiopathy. Clinical history includes a patient with known HIV infection presenting with right upper quadrant pain, fever, and jaundice. These are the findings. The liver is slightly enlarged with a coarse echo texture. No focal hepatic lesions are identified. The gallbladder is distended with thickened walls. No gallstones are visualized. Intrahepatic ducts. There is moderate dilatation of the intrahepatic bile ducts. The ductal walls appear irregular and thickened. The common bile duct is dilated, measuring approximately 9 mm in diameter. The ductal wall is irregularly thickened, and there is an echogenic sludge-like material within the duct. The pancreas is difficult to visualize. The kidneys and other organs are normal. This is the impression. The sonographic findings are suggestive of HIV cholangiopathy, characterized by dilatation of the intrahepatic and extrahepatic bile ducts with irregular thickening of the ductal walls and sludge-like material in the common bile duct. Clinical correlation is advised and further evaluation with MRCP or ERCP may be beneficial for confirmation and to assess for potential opportunistic infections or malignancies. Now we move on to malignancies. Intraductal cholangiocarcinoma, clinical history, patient presenting with progressive jaundice, weight loss, and right upper quadrant pain. These are the findings. The liver and gallbladder are normal. Mild dilation of the intrahepatic bile ducts is noted. There is a dilatation of the common bile duct measuring approximately 11 millimeters. Within the lumen of the common bile duct, a hypoechoic mass measuring approximately 2.5 centimeters in length is identified, causing obstruction. This mass appears to be arising from the ductal wall and is suggestive of an intraductal cholangiocarcinoma. The pancreas, kidneys, and other organs are normal. This is the impression. The sonographic findings are suggestive of an intraductal mass within the common bile duct, likely representing an intraductal cholangiocarcinoma causing biliary obstruction. Further diagnostic evaluation with ERCP and possibly a biopsy are recommended for definitive diagnosis and staging. Multidisciplinary consultation for treatment planning is also advised. This is a report of hilar cholangiocarcinoma. Clinical history, patient presenting with progressive jaundice, pruritus, and recent weight loss. The liver is normal in size with a slightly coarse echo texture. No focal hepatic lesions are identified. The gallbladder is distended with no evidence of polylithiasis or wall thickening. There is moderate to severe dilation of the intrahepatic bile ducts. Hilar region, a hypoechoic mass lesion is identified at the hepatic hilum, measuring approximately 3 centimeters in diameter. This mass appears to be causing obstruction at the confluence of the right and left hepatic ducts. Common bile duct. The extrahepatic portion of the common bile duct is not dilated, which is consistent with a hilar obstruction. The pancreas, kidneys, and other organs are normal. This is the impression. The sonographic findings suggest a hilar cholangiocarcinoma, also known as flat skin tumor, as evidenced by the presence of a mass at the hepatic hilum causing biliary obstruction with associated intrahepatic biliary ductal dilation. Further evaluation with MRCP or CT scan is recommended for better delineation of the tumor extent and involvement of vascular structures. A multidisciplinary approach including gastroenterology and surgical oncology consultations is advised for management planning. And this video is about pancreas ultrasound reporting. We will only talk about pancreatic pathologies. This is not a complete abdominal ultrasound report. The first case is acute pancreatitis. The clinical history in this example is acute abdominal pain, nausea, and vomiting. These are the findings. You can write the pancreas is enlarged and heterogeneous in echo texture with ill-defined margins. There are hypoechoic areas within the pancreas suggestive of edema. After that, you can write whether the pancreatic duct is dilated or not. In this example, it was dilated with a diameter of 6 millimeters. Then you can write about the common bile duct, and after that you can write about gallstones or biliary duct dilation. And here is the impression. The findings are suggestive of acute pancreatitis with edema and pancreatic ductal dilatation. It is important to write clinical correlation is recommended because a diagnosis is not entirely done on ultrasound alone. Now we move on to chronic pancreatitis. The clinical history in this case was chronic abdominal pain and history of alcohol abuse. In the findings for chronic pancreatitis, you can write the pancreas is hyperechoic with calcifications and lobular contour, and after that you can write whether the pancreatic duct is dilated or not. In this case, it was dilated with a diameter of 5 mm. After writing these statements, you can write about the CBD and comment on gallstones or biliary ductal dilatation. And in the end, you can write about free fluid in the abdomen. In the impression, you can write findings are suggestive of chronic pancreatitis with calcifications and a dilated pancreatic duct if the pancreatic duct is dilated. And in the end, you can write clinical correlation is recommended. This is a case of pancreatic atrophy. The clinical history was abdominal pain and history of chronic pancreatitis. In the findings for pancreatic atrophy, you can write the pancreas is hyperechoic and atrophic, and then you can write about the pancreatic duct and write its measurement. In the impression, you can write findings are suggestive of pancreatic atrophy, and then you can write about the pancreatic duct and its measurement, followed by this line, the appearance is consistent with chronic pancreatitis, and in the end you can write about clinical correlation. This report example is of pancreatic pseudocyst. The clinical history was abdominal pain and history of acute pancreatitis. These are the findings. A well-defined cystic lesion with internal echoes is identified in the pancreatic tail or body, wherever it is found. And then you can write its size. There will be no internal vascularity in a pseudocyst. After these lines, you can write about the pancreatic duct. In the impression, you can write findings are suggestive of a pancreatic pseudocyst. Then you can write its location. And after that, you can write about pancreatic ductal dilation. And in the end, you can write clinical correlation is recommended. Now we will talk about pancreatic duct stones. The clinical history was abdominal pain and history of chronic pancreatitis. In the findings, you can write about the hyperechoic pancreas with calcifications. The pancreatic duct is usually dilated. Here it is dilated with a diameter of 8 mm and contains multiple echogenic foci suggestive of stones. In this example, the patient had chronic pancreatitis. So in the impression, the findings are suggestive of chronic pancreatitis with calcifications and dilated pancreatic duct containing multiple stones, clinical correlation is recommended. Our next case is cystadenoma. The clinical indication can be an incidental finding on imaging. Its findings include a well-defined cystic lesion that is usually identified in the body of the pancreas. The cystic lesion has internal septations and solid components and appears to be a complex cyst. This is the impression. Findings are suggestive of a complex cystic lesion in the pancreas, likely a cystadenoma. Clinical correlation is recommended, and you must also write further imaging or biopsy may be necessary for definitive diagnosis. A microcystic adenoma can also be an incidental finding on imaging. Its findings include multiple small, well-defined cystic lesions which can range from 2 to 5 millimeters. These cystic lesions have thin, smooth walls and are uniform in size and shape. These findings are consistent with a microcystic adenoma. In the impression, we can write findings are suggestive of multiple small microcystic adenomas in the pancreas, and in the end we must write clinical correlation is recommended and further imaging or biopsy may be necessary for definitive diagnosis. Here is a case of pancreatic adenocarcinoma. The clinical history was abdominal pain and weight loss. In the findings you can write a hypoechoic mass and then you can write its location followed by its size. If the pancreatic duct is dilated, you must mention it and write its size as well. In this example, there was also invasion of the common bile duct with biliary ductal dilatation measuring 1.5 centimeters in diameter. This is the impression for adenocarcinoma. Findings are suspicious for pancreatic adenocarcinoma. Then its location is written, followed by the involvement of pancreatic duct and its invasion into the common bile duct with biliary ductal dilatation. The impression ends with the line of clinical correlation and further imaging or biopsy. Now we will look at insulinoma. It has a somewhat specific clinical history which will include hypoglycemia. These are the findings for this example. A well-defined hypoechoic mass is identified in the body of the pancreas, measuring 2 centimeters in diameter. There is no evidence of associated pancreatic ductal dilation or calculi. No evidence of invasion into adjacent structures. Color Doppler examination reveals no significant vascularity within the mass. This is the impression. Findings are suggestive of a well-defined hypoechoic mass in the body of the pancreas, likely an insulinoma. No evidence of associated pancreatic ductal dilation or calculi. Clinical correlation is recommended and further imaging or biopsy may be necessary for definitive diagnosis. Now we will look at metastasis. The clinical history here was history of cancer and suspicion for metastasis. In the findings for this example, a well-defined hypoechoic mass is identified in the pancreas and it was 2 centimeters in diameter. It has a smooth border and appears to be encapsulated. You can write these findings in the impression, and due to a history of cancer, this hypoechoic mass is likely representing a metastasis. This is a case of pancreatic injury. The clinical history here is trauma to the abdomen. In the findings, there is a heterogeneous appearance of the pancreas with areas of hypoechoic and hyperechoic parenchyma suggestive of pancreatic injury. There is also evidence of fluid collection adjacent to the pancreas, measuring 3 centimeters in diameter in this example. In the impression, you can write findings are suggestive of pancreatic injury with a heterogeneous appearance of the pancreas and evidence of adjacent fluid collection. Clinical correlation is recommended and further imaging may be necessary for definitive diagnosis and management. And this video is about spleen ultrasound reporting. We will see how to write ultrasound reports for the spleen. We will look at the clinical history, findings and impression. This is not a complete abdominal ultrasound report. The first case is of accessory spleen or splenule. The clinical history in this example is abdominal discomfort. These are the findings. The main spleen appears normal in size and shape. An additional well-defined hypoechoic structure is identified adjacent to the main spleen. Then the size of this accessory spleen is written. It demonstrates homogeneous echo texture similar to the main spleen, and there was no significant vascularity within the accessory spleen. No other abnormalities are noted elsewhere in the abdomen or pelvis. Here is the impression. An accessory spleen is identified adjacent to the main spleen. The accessory spleen appears normal in echo texture and does not demonstrate any significant abnormalities. And in the end, it is important to write clinical correlation is recommended to evaluate the significance and potential clinical impact of the accessory spleen. It is important to write about clinical correlation in the impression. Here is a case of splenomegaly. In the findings, you must mention that the spleen is enlarged and write its size. Here is the impression. Splenic enlargement consistent with splenomegaly is noted, characterized by heterogeneous echo texture. There were no focal lesions or cysts in this example. Further evaluation and correlation with clinical history and lab tests may be warranted to determine the underlying cause of splenomegaly. In the case of splenic cleft. The spleen is usually normal in size and shape. A well-defined hyperechoic linear structure is identified within the spleen. This structure runs horizontally along the short axis of the spleen, and in the end, the size of the splenic cleft is written. In the impression, a splenic cleft is identified within the spleen. This is a normal anatomic variant and does not represent any significant pathology or abnormality. Here is a case of a splenic cyst. These are the findings. A well-defined anechoic structure is identified within the spleen. It will have smooth borders and no internal septations. This is a case of a simple cyst. Then the size of the cyst is written. There were no solid components or calcifications within the cyst. Also, there was no vascularity or blood flow detected within the cyst. This is the impression. A splenic cyst is identified within the spleen. The cyst appears benign with no concerning features such as solid components or vascularity. Given the patient's clinical presentation and the characteristics of the cyst, further evaluation and management may be considered to ensure the stability and long-term follow-up of the splenic cyst. Here is a splenic cyst with calcified walls. In the findings, a well-defined cystic structure is identified. It demonstrates anechoic fluid content and is surrounded by calcified walls. No internal septations are observed within the cyst. No significant vascularity or blood flow is detected within the cyst. This is the impression. A splenic cyst with calcified walls is identified within the spleen. The presence of calcifications suggests a long-standing cyst. No internal septations are noted, and in the end, the line of clinical correlation is written. Here is a case of complex splenic cyst. The cyst demonstrates mixed echogenicity with both hypoechoic and hyperechoic areas. Internal septations and debris are observed within the cyst. No internal vascularity was detected within the cyst. This is the impression. A complex splenic cyst is identified within the spleen, demonstrating mixed echogenicity with internal septations and debris. No internal vascularity was observed, and it ends with the line of clinical correlation. Here is a report of hemangioma. In the findings, a well-defined hyperechoic lesion is identified. Then the size of the lesion is written. In the impression, you can mention the hyperechoic lesion, and you can end the impression by writing about clinical correlation. This is a report for lymphangioma. In the findings, a multicystic lesion is identified. It has multiple anechoic cysts with thin septations. The cystic spaces appear to be interconnected, creating a honeycomb or sponge-like appearance. In the impression, you can mention the lymphangioma and also mention multiple anechoic cystic spaces with thin septations, which resemble a honeycomb or sponge-like appearance. This is an example report of extramedullary hematopoiesis. The indication was a follow-up for extramedullary hematopoiesis in the spleen. The findings in this example were an enlarged spleen measuring 16.8 centimeters in length, and a hyperechoic lesion was seen. These findings are written in the impression, and the impression ends with the line of clinical correlation. The findings for an inflammatory pseudotumor include an enlarged spleen, and in this example, a well-defined hypoechoic mass is identified. It is heterogeneous in echotexture with areas of increased vascularity on Doppler imaging. These findings are written in the impression, and further evaluation including histopathological analysis and additional imaging modalities or biopsy are advised. Here is a case of lymphoma. The findings include an enlarged spleen. The splenic parenchyma is diffusely heterogeneous and hypoechoic. Multiple hypoechoic nodules are observed within the spleen, which demonstrate irregular margins and varying sizes. Doppler imaging reveals increased vascularity within the nodules. This is the impression. Significant splenomegaly with diffusely heterogeneous and hypoechoic splenic parenchyma. Multiple hypoechoic nodules with irregular margins and increased vascularity, suspicious for splenic lymphoma. Here is a case of splenic metastasis. The clinical history was a known primary malignancy. In the findings, the spleen was enlarged and multiple hypoechoic nodules are observed scattered throughout the splenic parenchyma. The nodules demonstrate irregular margins and variable sizes. Doppler imaging reveals minimal vascularity within the nodules. In the impression, you can write the findings and also mention the history of primary malignancy, and you can advise biopsy and further evaluation with other imaging modalities and a referral to an oncologist. Here is a case of splenic abscess. The indication was abdominal pain and fever. These are the findings. The spleen is enlarged and there is a well-defined hypoechoic and heterogeneous lesion, and this is its size, with internal echoes and posterior acoustic enhancement suggestive of a splenic abscess. There is surrounding hyperechogenicity and increased vascularity seen in the adjacent splenic parenchyma, suggestive of associated inflammation. These findings are written in the impression, and clinical correlation and further evaluation with imaging modalities such as CT scan are advised. This is a case of Gamma-Gandhi bodies. The clinical history was anemia. In the findings, there are multiple hyperechoic foci which demonstrate a popcorn appearance and are scattered throughout the spleen. This is the impression. These findings are consistent with the presence of gamma-Gandhi bodies in the spleen. Correlation with the patient's clinical history and further evaluation may be necessary if there are additional concerning findings or symptoms. Here is a case of sarcoidosis. The clinical history was fatigue and weight loss. These are the findings. Multiple hypoechoic nodules are observed within the splenic parenchyma. The nodules demonstrate irregular margins and variable echogenicity. Here is the impression. We do not write sarcoidosis in the impression because the findings overlap with other abnormalities such as metastasis or tumors. So after writing the findings, we will write about clinical correlation, lab results, and additional imaging studies. Here is a case of splenic trauma. These are the findings. There is evidence of splenic parenchyma disruption and irregularity with hypoechoic areas suggestive of hematoma formation. The splenic capsule is intact without evidence of rupture. No significant free fluid or active bleeding is seen in the abdomen. These findings are written in the impression. Then clinical correlation and further evaluation such as CT scans are advised. Here is a case of splenic infarcts. In the findings, multiple hypoechoic wedge-shaped areas are seen. The hypoechoic areas demonstrate a lack of vascularity on color Doppler imaging. In the impression, you can mention the multiple hypoechoic wedge-shaped areas as well as absence of vascularity within the hypoechoic areas, which support the diagnosis of infarcts. And then you can write about clinical correlation. Here is a case of splenic torsion. In the findings, the spleen appears enlarged. There is a focal area of hypoechoic and distorted splenic parenchyma. The splenic vessels, including the splenic artery and vein, show twisting or torsion. Color Doppler imaging demonstrates reduced or absent blood flow within the affected splenic vessels. In the impression, you can write about the focal hypoechoic and distorted splenic parenchyma and twisting of splenic vessels, and also mention the absence of blood flow within these twisted vessels. And in the end, you can write about clinical correlation. Here is a case of splenic artery aneurysm. In the findings, a focal dilatation of the splenic artery is identified. Then the size of this dilated artery is written. The aneurysm demonstrates a pulsatile flow within its lumen on color Doppler imaging. These findings are written in the impression as well. And in the end, you can write about further evaluation and clinical correlation. And this video is about kidney ultrasound reporting. We will see how to write kidney ultrasound reports. This will include findings and impression and will only involve the kidneys. Other organ reports are not included. The first case is of simple renal cyst. The clinical indication in this example is a routine ultrasound. These are the findings. You can write a well-defined anechoic cystic lesion is identified, and then you can write whether it is in the right or left kidney, and after that you can write the size of the cyst. Then you can write the cyst has a smooth border and thin walls consistent with a simple renal cyst. And then you can write about other abnormalities such as calculi or hydronephrosis. And in the end you can write about the appearances of the renal cortex and medulla. This is the impression for this example. Findings are consistent with a simple renal cyst. No evidence of associated renal calculi or hydronephrosis. No significant abnormalities identified. Clinical correlation is recommended. It is important to write about clinical correlation because a diagnosis is not only made on ultrasound alone. Our next case is polycystic kidney disease. These are the findings. Both kidneys are enlarged with multiple cystic lesions scattered throughout the renal parenchyma, ranging in size from a few millimeters to several centimeters in diameter. The cysts have thin walls and no solid components. The renal cortex is thinned and the medulla appears echogenic, consistent with chronic kidney disease. So this case of polycystic kidney disease was also associated with chronic kidney disease. In the impression you can mention the polycystic kidney disease with multiple cystic lesions present in both kidneys, and if there are other abnormalities as well, you can mention them here, and in the end you can write about clinical correlation. This is a case of kidney stones. The clinical history was flank pain and suspected renal stone. These are the findings. There is evidence of two echogenic foci in the upper pole of the left kidney. Then their measurements are written. There was no associated hydronephrosis or hydroureter in this case, and the right kidney was normal with no evidence of calculi or hydronephrosis, and the renal cortex and medulla appeared normal in both kidneys. In the impression you can mention the presence of stones and their measurements and in which kidney they are found, and also mention any associated hydronephrosis or hydroureter. After these lines you can write about the other kidney, and in the end you must write about clinical correlation. This is a case of staghorn stone. The clinical history was flank pain. You can write the size of the kidney, and then you can write there is evidence of a large echogenic structure in the central region consistent with a staghorn stone, and after that you can write the size of the stone and its location, and if it is causing hydronephrosis you can write that. In this case it was causing moderate to severe hydronephrosis of the entire right kidney, and if there is hydroureter present you can write about that. Then you can write about the appearance of the other kidney. This is the impression. Findings are consistent with a staghorn stone in the right kidney, causing moderate to severe hydronephrosis of the entire right kidney. There was no associated hydroureter and the left kidney was normal. Clinical correlation is recommended for appropriate management. This example is of nephrocalcinosis. Both the kidneys are diffusely hyperechoic and they have multiple small calcifications which are seen throughout the renal parenchyma. In this example, the corticomedullary differentiation is preserved. In the impression, you can write findings are consistent with bilateral nephrocalcinosis with multiple small calcifications seen throughout the renal parenchyma. The corticomedullary differentiation is preserved in this case, and there was no associated hydronephrosis. And in the end, it is important to write about clinical correlation. Here is a case of pyelonephritis. The kidney is enlarged and there is increased echogenicity of the renal parenchyma. The renal cortex is thickened and the corticomedullary differentiation is indistinct. Here is the impression. The findings are consistent with right-sided pyelonephritis. In this case, there was increased echogenicity, thickening of renal cortex, and loss of corticomedullary differentiation. This example is of chronic kidney disease. In the findings, both kidneys are small in size and have increased echogenicity of the renal parenchyma. Also, there is poor visualization of medullary pyramids. This is the impression. Findings are consistent with chronic kidney disease, with both kidneys small in size and increased echogenicity of the renal parenchyma. Also, there is poor visualization of medullary pyramids. Here is a case of renal failure. On ultrasound, the findings can be small size of both kidneys with increased echogenicity of the renal parenchyma. The corticomedullary differentiation is lost. In the impression, the findings are consistent with chronic renal failure, with both kidneys small in size, increased echogenicity of the renal parenchyma, and loss of corticomedullary differentiation. Ultrasound alone is not sufficient to diagnose a renal failure, so further evaluation is needed. You must mention this in the report. Now we move on to angiomyolipoma. In this report example, the left kidney measures 10 centimeters in length and appears normal in size and shape. A hyperechoic mass measuring 3.5 centimeters in greatest dimension is seen within the mid portion of the right kidney. The mass has a mixed echogenicity with areas of solid tissue and areas of fat attenuation, and there was no evidence of hydronephrosis or other significant abnormalities in the right kidney, and the left kidney was normal. In the impression, the findings are consistent with an angiomyolipoma in the mid portion of the right kidney. Then its size is written, followed by its echogenicity and appearance, and in the end, clinical correlation and further imaging may be warranted for appropriate management of the angiomyolipoma. This is a case of Wilms tumor. Its usual findings are a large heterogeneous mass with solid and cystic components and is surrounded by a thin capsule. Here is the impression. The findings are consistent with a large heterogeneous mass in the mid portion of the left kidney, measuring 8 centimeters in greatest dimension, with areas of solid and cystic components and a thin capsule, suspicious for Wilms tumor. The findings for renal cell carcinoma usually include a hypoechoic mass with irregular borders and heterogeneous echo texture. These findings are written in the impression. The hypoechoic mass with irregular borders and heterogeneous echo texture. These findings are suspicious for renal cell carcinoma. This report is for crossed-fused ectopia. These are the findings. The left kidney is fused with the lower pole of the right kidney, with the left renal pelvis communicating with the fused renal pelvis. The combined kidney measures 11.2 centimeters in length and appears to have a normal echo texture. The right ureter is seen arising from the fused renal pelvis, and the left ureter appears to be absent. These findings are written in the impression, and in the end, the line for clinical correlation is written. It is also important to mention other imaging modalities such as CT or MRI, which are necessary for appropriate management of this congenital anomaly. Here is a report for grade 1 hydronephrosis. There is mild dilatation of the collecting system measuring up to 10 millimeters in diameter. Here is the impression. Findings are consistent with grade 1 hydronephrosis of the right kidney without evidence of calculi, masses, or other focal lesions. In the report of a grade 2 hydronephrosis, you can write moderate dilatation of the collecting system, and you can write the regions involved. Then you can write the measurement of the collecting system. In this example, it was up to 20 millimeters in diameter. Here is the impression. Findings are consistent with grade 2 hydronephrosis of the right kidney without evidence of calculi, masses, or other focal lesions. And you can end the impression by writing about clinical correlation. This is a report for grade 3 hydronephrosis. You can write marked dilatation of the collecting system, and then you can mention the location. Here the collecting system measurement was 30 millimeters in diameter. This is the impression. The findings are consistent with grade 3 hydronephrosis, and the impression ends with the statement of clinical correlation. In grade 4 hydronephrosis, there is severe dilatation of the collecting system and there is significant thinning of the renal cortex with loss of normal renal parenchymal thickness, which in this case was less than 5 millimeters in some areas. And here is the impression. Findings are consistent with grade 4 hydronephrosis with significant thinning of the renal cortex. These findings are concerning for obstructive uropathy leading to potential renal damage or renal failure. You must also write about urgent urological intervention because urgent treatment is required in this case. And this video is about small bowel ultrasound reporting. You will learn how to write ultrasound reports regarding small bowel pathologies. The reports will include the findings and the impression. The reports will focus mainly on small bowel findings. We will start with a normal report. The indication is suspected small bowel obstruction. Here are the findings of small bowel. The loops of the small bowel are within normal limits. There are no signs of small bowel obstruction. Wall thickness of the examined small bowel loops is consistent throughout and measures within normal limits. Peristalsis is observed and appears normal. No signs of abnormal fluid collection or free fluid in the abdomen. These are other observations. The liver, spleen, gallbladder, pancreas, kidneys, and bladder were briefly evaluated and appeared grossly unremarkable. No masses or lymphadenopathy were identified. Here is the impression. Normal appearance of the small bowel without evidence of obstruction or wall thickening. No free fluid in the abdomen. No further ultrasound evaluation is required based on the sonographic findings. Clinical correlation is recommended. This is a case of enteritis. Clinical indications are clinical suspicion of enteritis based on symptoms of abdominal pain, diarrhea, and fever. These are the findings. Multiple loops of the small bowel demonstrate increased wall thickness, measuring up to 5 millimeters. The normal range is up to 3 millimeters. Bowel wall layers show stratification. Increased vascularity of the affected bowel loops is seen on color Doppler, indicating hyperemia. Peristalsis is diminished in the thickened segments. No evidence of obstruction or intussusception. Small amount of free fluid noted around the affected bowel loops. The rest of the scan was unremarkable. This is the impression. Sonographic findings consistent with enteritis, characterized by increased bowel wall thickness, hyperemia, and surrounding free fluid. No evidence of small bowel obstruction or other complicating features. Further clinical evaluation and possible laboratory workup to identify the underlying cause of the enteritis, follow-up imaging or referral to a gastroenterologist may be warranted based on clinical progression or lack of resolution. This is a report for small bowel obstruction. Indication: clinical symptoms suggestive of small bowel obstruction, including abdominal pain, vomiting, and inability to pass gas or stool. These are the findings in the small bowel. Multiple dilated small bowel loops identified with diameters exceeding 3 centimeters. The content within these dilated loops is primarily fluid, with some evidence of intraluminal gas. There is a notable absence of peristalsis in the dilated segments, referred to as static bowel loops. To and fro peristaltic movements were observed in certain loops, suggesting a functional obstruction. The transition point was not definitively identified on this examination. Increased amounts of free fluid noted within the abdomen, especially between the dilated bowel loops. The rest of the scan was unremarkable. This is the impression. Sonographic findings highly suggestive of a small bowel obstruction, characterized by dilated static bowel loops and the presence of ascites. The underlying cause of the obstruction, example, adhesions, hernia, or mass, was not identified on this examination. Urgent surgical consultation is advised. Complementary imaging, such as a CT scan of the abdomen and pelvis, may be beneficial to further elucidate the cause and location of the obstruction. This is a report for intussusception. Indication is a 3-year-old with intermittent abdominal pain, current jelly stools, and a palpable abdominal mass. These are the findings. There is a segment of the small bowel that demonstrates the classic target or donut sign on transverse view, consistent with intussusception. On the longitudinal view, the multi-layered appearance, often termed the sandwich sign, is evident, further supporting the diagnosis. The intussusception measures approximately 4 centimeters in length. No evidence of free fluid or bowel wall ischemia around the intussusception at the time of the study. No identifiable lead point such as a mass or polyp within the intussuscepted segment. No other abnormalities were found. This is the impression. Sonographic findings consistent with ilioileal small bowel intussusception. No identified lead point or signs of complications at the time of this examination. Immediate pediatric surgical consultation is advised. Depending on the clinical situation and duration of symptoms, an air or contrast enema may be considered for reduction, or direct surgical intervention might be required. This is a report for midgut volvulus. Indication is a 6-month-old with acute onset of bilious vomiting, irritability, and a distended abdomen. These are the findings. There is a swirling of the mesentery and the superior mesenteric vessels, known as the whirlpool sign, consistent with midgut volvulus. The superior mesenteric artery and the superior mesenteric vein demonstrate an abnormal relationship, with the superior mesenteric vein positioned to the right of the SMA. Dilated loops of bowel are seen proximal to the area of torsion, while downstream loops appear collapsed. Reduced bowel-wall perfusion is observed in certain segments, raising concern for potential bowel ischemia. The rest of the study was normal. This is the impression. Sonographic findings consistent with midgut volvulus, signs suggestive of compromised bowel perfusion, which requires urgent attention. Immediate pediatric surgical consultation is imperative. This is a surgical emergency and prompt intervention is necessary to preserve bowel viability. Here is a report of Crohn's disease. Indication is chronic abdominal pain, diarrhea, weight loss, and suspected Crohn's disease. These are the findings. Multiple non-contiguous segments of the small bowel demonstrate increased wall thickness, with some areas measuring up to 7 mm. Increased vascularity, hyperemia, is noted in these segments on color Doppler examination. A few small bowel loops are adherent to each other, forming inflammatory masses. There is evidence of a creeping fat sign, where the mesenteric fat appears to wrap around the bowel loops. No abscess, fistula, or significant free fluid is identified in the examined abdomen. Mild mesenteric lymphadenopathy was observed, with a few nodes measuring up to 1.5 cm in short axis. The other organs were normal. Here is the impression. Sonographic findings are consistent with Crohn's disease, affecting multiple segments of the small bowel. Inflammatory changes, including wall thickening, hyperemia, and the presence of creeping fat, support the diagnosis. No complications such as abscesses or fistulas identified at the time of this examination. Correlation with clinical and laboratory findings is recommended. Further evaluation with MR enterography or ileocolonoscopy may be beneficial for a comprehensive assessment of disease extent and activity. Consideration for gastroenterology consultation for medical management. And in this video, you will learn how to write ultrasound reports on hernias. The reports will include 3 parts: the clinical history, the findings, and the impression. The first case is an epigastric hernia. This is the clinical history. Patient presents with intermittent upper abdominal pain, particularly after meals. These are the findings. Epigastric region. An oval-shaped defect is noted in the linea alba, approximately 3 cm above the umbilicus. The defect measures approximately 2 cm in its largest dimension. There is evidence of preperitoneal fat protruding through this defect, consistent with an epigastric hernia. No bowel loops were seen within the hernia during the time of examination. The second section of the findings is hernia content. The herniated content appears to be primarily preperitoneal fat with no evidence of intestinal or omental involvement. There is no sign of strangulation or obstruction. Abdominal wall. The surrounding abdominal wall musculature appears intact with no additional defects observed. The rectus muscles are normal in appearance with no signs of diastasis recti, which is a condition in which large abdominal muscles separate. Vascularity. Doppler imaging did not reveal any abnormal blood flow patterns in the area of the hernia, suggesting no complications like strangulation or ischemia at the time of the scan. The other organs in the abdomen appeared within normal limits. No abnormalities were detected that could be contributing to the patient's symptoms. And here is the impression. The ultrasound examination reveals an epigastric hernia measuring approximately 2 centimeters in diameter, containing preperitoneal fat without evidence of bowel involvement. No signs of acute complications such as strangulation or ischemia are noted. Clinical correlation and surgical consultation are recommended for further management. This is a report for a Spigelian hernia. Clinical history. Patient reports localized pain and swelling along the lateral edge of the rectus abdominis muscle. These are the findings. Hernia location and description. A defect in the Spigelian fascia, approximately 4 centimeters below the umbilicus, along the lateral border of the rectus abdominis muscle. The defect measures around 1.5 centimeters in diameter. Hernia contents. The hernia sac appears to contain preperitoneal fat and a small segment of bowel loop, which seems to be reducible. There is no evidence of bowel obstruction or strangulation at the time of the examination. In the abdominal wall, no other abnormalities were noted. The rectus muscles and other facial planes appear intact. Color Doppler imaging did not reveal any abnormal vascular flow within the herniated contents, suggesting no immediate vascular compromise. The surrounding structures were normal. This is the impression. Ultrasound findings are consistent with a Spigelian hernia measuring approximately 1.5 centimeters in diameter, containing preperitoneal fat and a small bowel loop. No immediate complications such as strangulation or obstruction were noted. However, given the presence of a bowel loop, there is a potential risk for complications in the future. This is the continuation of the impression. Clinical correlation is advised, particularly with the patient's symptomatology. Surgical consultation is recommended for further evaluation and management, considering the risk of potential complications. Patient education regarding symptoms of strangulation or obstruction is recommended, advising urgent medical attention if such symptoms arise. Now we have a report example of umbilical hernia. Clinical history: patient complains of acute onset of pain at the umbilical region with a palpable bulge, suspecting a complication of a known umbilical hernia. These are the findings: hernia location and characteristics. There is a defect in the umbilical region measuring approximately 2.2 centimeters in maximum diameter. The defect corresponds to the site of the patient's palpable bulge and reported pain. Hernia contents: the hernia sac is seen containing preperitoneal fat. The echo texture of the herniated fat appears hyperechoic and heterogeneous, suggestive of compromised fat, potentially indicating strangulation. No bowel loops were identified within the hernia sac. Vascular flow: Doppler imaging demonstrates decreased to absent blood flow within the herniated fat, consistent with strangulation. The surrounding abdominal wall musculature is unremarkable. There is no free fluid or other abnormalities noted in the accessible peritoneal cavity. Here is the impression. Findings are consistent with an umbilical hernia measuring approximately 2.2 centimeters, containing strangulated preperitoneal fat. The absence of blood flow within the herniated tissue is concerning and suggests urgent need for clinical correlation and potential surgical intervention. Now we have a case of hypogastric linea alba hernia. Clinical history: patient presents with persistent pain and swelling in the lower central abdominal region. Known history of a small hypogastric hernia. Recent exacerbation of pain with associated nausea. These are the findings: hernia location and size. A focal defect is identified in the linea alba in the hypogastric region, measuring approximately 2.5 centimeters in its largest diameter. Hernia contents: the hernia sac is seen containing what appears to be preperitoneal fat. The fat within the hernia demonstrates an increased echogenicity and heterogeneous appearance, suggesting the possibility of strangulation. Vascular flow: Doppler imaging reveals significantly reduced vascular flow within the herniated fat, further supporting the suspicion of strangulation. The surrounding structures were unremarkable, and there was no free fluid in the visible peritoneal cavity. This is the impression. The ultrasound findings are suggestive of a hypogastric linea alba hernia measuring approximately 2.5 centimeters with contained strangulated preperitoneal fat. The diminished vascular flow within the herniated tissue is concerning and may indicate a need for urgent intervention. Immediate surgical consultation to assess the need for urgent herniorrhaphy or hernioplasty is advised. Analgesia as required and monitoring for signs of systemic involvement such as fever or increased white blood cell count are recommended. The patient should be advised of the serious nature of these findings and instructed to seek immediate medical attention for any worsening of symptoms. This is a report for incisional hernia. Clinical history. Patient has a history of abdominal surgery, cholecystectomy, 2 years prior. He now presents with a palpable bulge and discomfort at the surgical scar site, particularly on exertion. These are the findings: location and description of the hernia. An abnormal defect is noted in the anterior abdominal wall at the site of the previous surgical scar, consistent with an incisional hernia. The defect measures approximately 3 cm in its longest dimension. Contents of the hernia. The hernia sac contains omental fat and a loop of small bowel. The bowel loop appears mildly distended but demonstrates peristaltic activity, and there is no evidence of obstruction. Hernia sac and surrounding tissues. The sac is well defined with no signs of rupture. The overlying skin and subcutaneous tissue appear unremarkable. Vascular flow. Doppler imaging shows normal blood flow in the herniated bowel loop with no signs of vascular compromise. The musculature around the hernia site appears attenuated but otherwise unremarkable. This is the impression. Ultrasound findings are consistent with an incisional hernia at the site of a previous surgical scar, measuring approximately 3 cm in diameter. It contains omental fat and a small bowel loop without evidence of obstruction or strangulation. Surgical evaluation is recommended to assess the need for repair, considering the size of the hernia and the involvement of a bowel loop. The patient should be advised to monitor for symptoms of incarceration or strangulation, such as sudden increase in pain, nausea, or vomiting, and to seek immediate medical attention if these occur. Follow up as clinically indicated, especially if there are changes in symptoms. This is a case of Richter hernia. Clinical history. Patient presents with localized pain in the right groin area, with a history of intermittent swelling in the same region. No prior history of abdominal surgery. Hernia location and description. A small focal defect is noted in the right inguinal canal, suggestive of a hernia. The defect measures approximately 1.8 cm. Hernia contents. The hernia sac appears to contain a portion of the bowel wall, consistent with a partial entrapment as seen in Richter hernias. The entrapped bowel wall is thickened and shows reduced peristalsis compared to the adjacent normal bowel. Vascular flow. Doppler imaging demonstrates reduced blood flow in the entrapped segment of the bowel, raising concern for compromised bowel viability. Surrounding structures. The rest of the visualized bowel appears normal. The adjacent inguinal canal structures appear unremarkable. The abdominal wall muscles were also unremarkable. This is the impression. Findings are suggestive of a Richter hernia in the right inguinal region, characterized by partial entrapment of the bowel wall. The reduced blood flow in the affected segment is concerning and indicates a risk of ischemia. Urgent surgical consultation is recommended given the risk of bowel ischemia and potential for strangulation in a Richter hernia. Close clinical monitoring for signs of bowel obstruction or strangulation, such as worsening pain, nausea, or vomiting. Follow-up imaging or surgical exploration may be necessary depending on the patient's clinical evolution and surgical assessment. Now we have a report of a direct inguinal hernia. Clinical history. Patient reports a bulge in the right groin area, more prominent with standing and straining, and reduces when lying down. No prior history of abdominal or groin surgeries. These are the findings. Location and characteristics of the hernia. A protrusion is noted medial to the inferior epigastric vessels in the right inguinal region, consistent with a direct inguinal hernia. The hernia measures approximately 2 cm in maximum diameter. Contents of the hernia. The hernia sac contains preperitoneal fat and a small bowel loop, which appears to be freely reducible. No signs of bowel obstruction are evident. The vascular flow is normal on Doppler imaging in the herniated bowel loop. The adjacent abdominal wall musculature appears intact, and no other abnormalities are noted. The contralateral side, which is the left side, in this example, the hernia is found on the right side. Examination of the left inguinal region did not reveal any herniation or abnormality. This is the impression. Ultrasound findings are consistent with a right direct inguinal hernia, approximately 2 cm in size, containing preperitoneal fat and a small bowel loop. There is no evidence of runt strangulation or obstruction. Clinical correlation is recommended, particularly in relation to the patient's symptoms and physical examination findings. Surgical consultation may be considered for hernia repair, particularly given the size and content of the hernia. Patient should be advised to monitor for symptoms of incarceration or strangulation, such as sudden pain, nausea, or vomiting, and seek immediate medical attention if these occur. Now we move on to an indirect inguinal hernia. Clinical history. Patient reports intermittent bulging in the left inguinal area, especially noticeable during coughing or strenuous activities. No significant past medical or surgical history. Location and characteristics of the hernia. A protrusion is identified lateral to the inferior epigastric vessels in the left inguinal canal. Characteristic of an indirect inguinal hernia. The hernia extends through the internal inguinal ring, measuring approximately 2.5 cm in maximum diameter. Contents of the hernia. The hernia sac predominantly contains mental fat. There is also a small portion of the bowel, which appears compressible and shows peristaltic activity. No signs of bowel obstruction or strangulation are observed. The vascular flow was normal. The surrounding inguinal canal structures, including the spermatic cord, appear normal. The contralateral side was normal. This is the impression. The ultrasound findings are consistent with a left indirect inguinal hernia, measuring approximately 2.5 cm, containing omental fat and a small portion of bowel. No immediate complications such as strangulation or obstruction are noted. Given the patient's age and activity level, a surgical consultation is recommended to discuss potential hernia repair. The patient should be advised to monitor for signs of incarceration or strangulation, such as increased pain, nausea, or changes in bowel habits, and to seek immediate medical attention if these symptoms occur. A follow-up ultrasound may be considered if there is a change in symptoms or clinical concern for hernia progression. Now we move on to a pantaloon hernia. Clinical history. Patient presents with a long-standing history of a bulge in the right groin area, which has recently become more prominent and occasionally painful. No previous history of abdominal or groin surgery. These are the findings, location and characteristics of the hernia. Two distinct hernia sacs are noted in the right inguinal region. These sacs appear to straddle the inferior epigastric vessels, characteristic of a pantaloon hernia, also known as a saddleback hernia. In simple words, the epigastric vessel is surrounded by hernia contents, which can be indicative of a pantaloon hernia. The vessel is sandwiched between two hernia sacs. Contents of the hernia. One sac located laterally, indicative of an indirect hernia component, contains omental fat and a segment of bowel. The medial sac, suggestive of a direct hernia component, predominantly contains preperitoneal fat. Vascular flow. Doppler imaging reveals normal blood flow within the herniated bowel loop. No signs of vascular compromise are observed. Inguinal canal and surrounding structures. The inferior epigastric vessels appear intact and unobstructed. The adjacent structures, including the spermatic cord and abdominal wall musculature, are normal. The contralateral site is normal. Here is the impression. The ultrasound findings are consistent with a pantaloon hernia on the right side, comprising both indirect and direct components, with involvement of omental fat and bowel in the hernia sacs. There is no evidence of bowel obstruction or strangulation at the time of this examination. Given the complex nature of a pantaloon hernia, surgical consultation is advised for further evaluation and potential repair, especially considering the patient's symptoms. The patient should be counseled to monitor for signs of incarceration or strangulation, such as sudden pain, nausea, vomiting, or changes in bowel movements. A follow-up ultrasound or cross-sectional imaging may be beneficial for surgical planning or if there is a change in clinical status. Now we have a report of MEN hernia. Clinical history. Patient presents with painful swelling in the right groin area, which has increased over the past week. History of occasional lower abdominal pain. Now we have the findings. Location and characteristics of the hernia. A hernia sac is identified within the right inguinal canal, extending through the external inguinal ring. The hernia appears to be an indirect type based on its position relative to the inferior epigastric vessels. Contents of the hernia. Remarkably, the hernia sac contains a tubular, non-compressible structure with a blind end consistent with an inflamed appendix, Amiens hernia. The appendix measures approximately 6 mm in diameter and exhibits hyperemia on Doppler examination. The surrounding structures. The cecum is located in close proximity to the internal inguinal ring without any evidence of perforation or abscess formation. The adjacent bowel loops appear unremarkable. The abdominal wall musculature and overlying subcutaneous tissue are normal. The contralateral side is unremarkable. Here is the impression. The findings are consistent with a right-sided indirect inguinal hernia containing an inflamed appendix. No evidence of perforation or abscess is noted at the time of this examination. Urgent surgical consultation is recommended given the potential for complications associated with an inflamed appendix within a hernia sac. Preoperative antibiotics may be considered in view of the inflammation. Monitoring for signs of worsening inflammation, perforation, or systemic infection is advised. Now we have a case of scrotal hernia. Clinical history. The patient presents with a visible and palpable bulge in the right scrotum, which increases in size when standing or straining. History of inguinal hernia repair on the right side a few years ago. These are the findings. Location and characteristics of the hernia. A fluid-filled sac is observed within the right scrotum. This sac is continuous with the right inguinal canal and is consistent with a scrotal hernia. It measures approximately 4 cm in its largest dimension. Hernia contents. The hernia sac contains omental fat and a small segment of the small intestine. No signs of bowel obstruction or strangulation are evident. The vascular flow is normal and the surrounding structures are unremarkable. The contralateral side is normal. This is the impression. The ultrasound findings are consistent with a scrotal hernia on the right side, extending through the right inguinal canal. The hernia contains omental fat and a small segment of the small intestine without evidence of obstruction or strangulation. Surgical consultation is advisable to assess the need for hernia repair, particularly given the patient's symptoms and history of hernia repair on the same side. The patient should be informed to monitor for symptoms of incarceration or strangulation, such as increased pain, nausea, or changes in bowel habits, and to seek immediate medical attention if these symptoms occur. Consideration for follow-up ultrasound or imaging if there is a change in clinical status. Now we have a case of femoral hernia. Clinical history. 53-year-old female with a history of groin pain and a palpable mass in the right groin region, suspected femoral hernia. Here are the findings. Location and characteristics of the hernia. There is an echogenic mass lesion noted in the right femoral canal, lateral to the pubic tubercle and inferior to the inguinal ligament, consistent with a femoral hernia. Hernia contents. The hernia sac contains omental fat and no bowel loops. No signs of incarcerated or strangulated bowel are observed. The vascular flow is normal. The surrounding structures and contralateral side are unremarkable. This is the impression. Ultrasound findings suggestive of a right-sided femoral hernia containing omental fat. There is no evidence of bowel involvement or strangulation. Clinical correlation and consideration for surgical evaluation for the management of femoral hernia. Follow-up ultrasound may be considered if symptoms persist or change. Urgent evaluation is recommended if signs of bowel obstruction or strangulation develop. And this video is about appendix ultrasound reporting. We will see how to write findings and impression for diseases related to the appendix, which mainly includes appendicitis. Here is an example of acute appendicitis. This is the clinical presentation. The patient presented with complaints of persistent right lower abdominal pain and tenderness, accompanied by nausea and a low-grade fever. Suspected diagnosis of appendicitis. These are the findings. Ultrasound examination of the right lower abdomen was performed using a high-frequency linear transducer. The appendix was identified as a blind-ending tubular structure arising from the cecum in the expected anatomical location. Then you can write the size of the appendix. You can write the length if possible, and then you can write the diameter. Here it is 1.2 centimeters. And then you can write about mural thickening and increased echogenicity within the appendiceal wall, indicative of inflammation. There was also the presence of fluid-filled distension within the lumen of the appendix. After that, you can write about periappendiceal structures and mention localized fat stranding and increased vascularity. In this example, no appendicolith, that is, a calcified deposit, was visualized within the lumen of the appendix. Here is the impression for this example. The ultrasound findings are consistent with acute appendicitis. The presence of an enlarged, inflamed, and fluid-filled appendix, along with surrounding periappendiceal inflammation, supports the diagnosis. And then you can write, it is recommended to consult a surgeon for further evaluation and consideration of appendicectomy as a definitive treatment. Here is a case of appendicitis with appendicolith. The clinical presentation is almost similar to the previous one. This patient had anorexia. These are the findings. You can start by writing which type of transducer was used. Then you can write about the visualization of the appendix, followed by the size, and after that you can comment on the appendiceal wall. If the appendicolith is visualized, you can write within the lumen of the appendix, an appendicolith was identified as a hyperechoic calcified structure, and then you can write the size of the appendicolith. Next, you can write about periappendiceal structures, where you can mention localized fat stranding and increased vascularity. This is the impression. All the main findings of the appendix as well as the findings of periappendiceal structures are written, and in the end, surgical consultation is recommended for further evaluation and treatment. Here is a case of perforated appendix. This is the clinical presentation. There was severe abdominal pain in the right lower quadrant, fever, and signs of generalized peritonitis. There was strong clinical suspicion of a perforated appendix. These are the findings. Most of the findings are similar to the ones we saw earlier in appendicitis. However, there is a focal defect in the appendiceal wall, indicative of perforation. There was evidence of free fluid adjacent to the perforated site, suggestive of intra-abdominal fluid collection. These are the comments on periappendiceal structures which showed signs of inflammation, including localized fat stranding, increased vascularity, and free fluid within the right iliac fossa. These findings were indicative of peritonitis secondary to a perforated appendix. Here is the impression. The ultrasound findings are consistent with a perforated appendix. The presence of a dilated, thick-walled appendix with evidence of focal perforation and associated free fluid suggests the development of intra-abdominal sepsis. Urgent surgical intervention is warranted for exploratory laparotomy, abscess drainage, and appendectomy to prevent further complications and manage the intra-abdominal infection. And this video is about prostate ultrasound reporting. We will see how to write reports related to the prostate gland. The reports will include findings and impression. Our first case is prostatic calcification, and these are the findings. The prostate gland appears enlarged, then its measurement is written. There are multiple hyperechoic foci detected within the gland, suggestive of prostatic calcifications. The calcifications are predominantly located in the transitional zone of the prostate. You can write more about the calcifications. You can write about their size range, and then you can also mention whether there is any posterior acoustic shadowing present or not, and then you can write about the surrounding prostatic tissue, which in this example appears homogeneous, and there were no focal abnormalities or masses. Here is the impression. Enlarged prostate gland with multiple prostatic calcifications, predominantly in the transitional zone. There were no focal abnormalities or masses. And in the end, you must write clinical correlation is recommended to determine the underlying cause of the patient's lower urinary tract symptoms. It is important to write about clinical correlation in the impression. Now we will look at benign prostatic hyperplasia. In the findings, the prostate gland appears enlarged, then its size is written. In this example, the overall echo texture of the gland is heterogeneous, with increased glandular density and decreased echogenicity compared to adjacent tissues. There is evidence of symmetric enlargement involving both the central and transitional zones of the prostate gland. The transition zone is notably hypertrophied, causing a protrusion into the prostatic urethra, which is consistent with BPH. The antero-posterior diameter of the transition zone measures approximately 3 centimeters. All these findings are written in the impression, and you can end the impression with further clinical correlation and evaluation, including a detailed medical history, physical examination, and laboratory tests are recommended to guide appropriate management options. Now we will look at reports for Grade 1 intravesical prostatic protrusion. In the findings, you can write the size of the prostate, and then you can write about its echo texture. Then you can mention the evidence of a mild intravesical prostatic protrusion graded as Grade 1. The prostatic urethra shows a slight elevation of the posterior bladder wall, with the protruding part of the transition zone extending less than 5 millimeters into the bladder lumen. Then you can write about any focal lesions, cysts, or calcifications that are identified, and then you can write about the seminal vesicles. In the impression, you can mention the Grade 1 intravesical prostatic protrusion and write the depth, which will be less than 5 millimeters. And after that, you can write consultation with a urologist is recommended to discuss the findings of this ultrasound examination and to determine appropriate treatment options based on the patient's clinical history and symptoms. For Grade 2 IPP, the findings will include the protrusion extending between 5 and 10 millimeters into the bladder lumen. Then you can write about any focal lesions, cysts, or calcifications that are present, and then you can write about the seminal vesicles. In the impression, you can mention the enlarged prostate gland and the Grade 2 intravesical prostatic protrusion. Also mention that the protrusion is between 5 to 10 millimeters into the bladder lumen, and then you can write about any mild distortion that was seen in the bladder neck, and if there is any slight compression of the urethra, you can also mention that. These are the findings for Grade 3 IPP. The prostatic urethra shows a pronounced elevation of the posterior bladder wall, with the protruding part of the transition zone extending more than 10 millimeters into the bladder lumen. Moderate distortion of the bladder neck and compression of the urethra are observed. Then you can write about any other findings that are seen within the prostate gland, the bladder, or the seminal vesicles. In the impression, you can mention these findings, especially mentioning the protrusion of more than 10 millimeters into the bladder lumen. And in the end, you can write about clinical correlation. Now we will look at prostate cancer. Here is the clinical history of a patient. Elevated prostatic specific antigen or PSA level and an abnormal digital rectal examination suggestive of possible prostate cancer. These are the findings. The prostate gland appeared enlarged and asymmetrical. There is presence of multiple hypoechoic nodules with irregular margins and increased vascularity within the peripheral zone. After that, you can write about other abnormalities seen, and the appearance of the seminal vesicles. You can also mention if there is any significant lymphadenopathy observed within the pelvic region. You can write these findings in the impression as well, and in the end you can advise further evaluation and diagnostic procedures including prostate biopsy and additional imaging studies to confirm the diagnosis and determine the extent of the disease. This is a case of prostatitis. In the findings, you can first write the size of the prostate, and then you can write about the overall echo texture. In this example, it was homogeneous and isoechoic. There is evidence of diffuse hypervascularity within the prostate gland, indicative of increased blood flow and inflammation. The periurethral region and surrounding tissues demonstrate mild edema consistent with prostatic inflammation. After that, you can write about other abnormalities if they are present, and also comment on lymphadenopathies. You can write the main findings in the impression, and you can end the impression by writing about clinical correlation and further evaluation. This is a case of prostatic abscess. These are the findings. The prostate gland appears enlarged, measuring approximately 5 centimeters in its largest dimension. The overall echo texture of the gland is heterogeneous, with areas of hypoechoic and hyperechoic regions. A well-defined fluid-filled collection is visualized within the prostate gland, measuring approximately 3 centimeters in diameter. The collection demonstrates internal echoes and septations consistent with an abscess. There is evidence of surrounding inflammatory changes with increased vascularity and edema in the adjacent prostatic tissue. Then you can write about any other abnormalities that are noted. You can write the findings of the prostatic abscess in the impression, and in the end you can advise consultation with a urologist for further evaluation and appropriate treatment planning. Here is an example of utricle cyst. This is the clinical history, urinary frequency and intermittent hematuria. These are the findings. A well-defined cystic structure is identified within the prostatic urethra, anterior to the verumontanum, consistent with a utricle cyst. Then the size of the cyst is written, and it demonstrates thin, smooth walls. There is no evidence of internal echoes or solid components within the cyst. In the impression, you can conclude that the findings are consistent with the presence of a utricle cyst, and in the end you can write about clinical correlation. Here is a case of prostatic cyst. Its findings include a well-defined cystic structure within the prostate gland. The cyst demonstrates thin, smooth walls and contains clear fluid. There are no internal echoes or solid components within the cyst. You can write these findings in the impression, and you can end the impression by writing about clinical correlation.
And this video is about fast ultrasound reporting. FAST stands for Focused Assessment with Sonography for Trauma. It is an emergency ultrasound performed in cases of trauma such as motor vehicle accidents or falls. You will learn how to write fast ultrasound reports. The reports will include the patient information, findings, impression, and recommendations. Our first example is regarding pericardial effusion. This is a report on a patient with pericardial effusion due to motor vehicle accident. Patient information: age 45, gender male, medical history, known case of hypertension. It is important to write the time of ultrasound. It is very important to write this time in a fast scan report. The date is January 8, 2024 and the time of scan is 10:30 a.m. Clinical indication: suspected cardiac trauma, post-vehicular accident, complaints of chest pain and shortness of breath. After that, you can write the findings. Subxiphoid view: a large anechoic fluid collection observed in the pericardial sac, approximately 2 centimeters in depth surrounding the cardiac chambers. Other views: parasternal and apical views reconfirm the presence of pericardial effusion. No signs of pneumothorax or abdominal fluid noted. Quantification: approximate fluid volume is difficult to quantify but appears significant. This is the impression. There is a significant pericardial effusion noted. No immediate signs of cardiac tamponade observed, but clinical correlation is recommended given the potential for rapid progression. The heart chambers are not compressed at the moment of examination. You can also add another section, that is recommendations, and you can advise further management and interventions in this section. The pericardial effusion is considerable and warrants urgent attention. Recommend immediate cardiology consultation for potential pericardiocentesis. Close monitoring for signs of cardiac tamponade is advised. Further echocardiography could be beneficial for a more detailed cardiac assessment. Patient stable during the examination. Vital signs to be closely monitored given the potential for rapid hemodynamic changes. This is an example report regarding abdominal pelvic fluid. The patient is 30 years old, gender female, no significant past medical history. Date and time: 8 January 2024, 2 p.m. Clinical indication: evaluation for internal bleeding following a motor vehicle collision, patient presenting with abdominal pain and hypotension. These are the findings. Right upper quadrant: no free fluid observed in the hepatorenal space, that is Morrison's pouch. Left upper quadrant: trace amount of hypoechoic fluid noted in the splenorenal recess. Suprapubic view: small amount of free fluid seen in the rectouterine pouch, that is pouch of Douglas. Pericardial view: the subxiphoid view. Pericardium appears normal with no evidence of effusion. This is the impression. Minimal fluid accumulation in the left upper quadrant and pelvis, potentially indicative of internal bleeding. Absence of fluid in the right upper quadrant and around the pericardium. These are the recommendations. The presence of fluid in the splenorenal recess and the pelvis, although small, is concerning in the context of trauma. Recommend further diagnostic imaging such as a CT scan for a more comprehensive evaluation of internal injuries. Close monitoring of the patient's vital signs and hemodynamic status is advised. Surgical consultation may be considered depending on the patient's clinical evolution and additional imaging results. Patient remains hemodynamically stable but reports increasing abdominal discomfort. Continued observation and reassessment are essential. Here is another case of abdominal pelvic fluid. The patient is 52 years old, male. The date and time are 9th January 2024, 11:15 a.m. Clinical indication: evaluation for potential intra-abdominal bleeding following a fall, complaints of right upper quadrant pain. These are the findings: right upper quadrant, moderate amount of free fluid observed in Morrison's pouch, suggestive of intra-abdominal bleeding. Left upper quadrant, no free fluid detected in the splenorenal recess. Subphrenic space, small collection of hypoechoic fluid noted in both right and left subphrenic spaces, more pronounced on the right. Pelvic view, no free fluid observed in the rectovesical pouch. Pericardial view, no evidence of pericardial effusion. This is the impression: the presence of fluid in Morrison's pouch and subphrenic spaces, particularly on the right, is highly suggestive of intra-abdominal bleeding, possibly related to liver injury or rupture. No fluid accumulation noted in the pelvis or around the heart. These are the recommendations. Given the findings of free fluid in the abdomen, urgent surgical consultation is recommended. Further diagnostic modalities such as CT scan may be necessary for a more detailed evaluation of the extent and source of bleeding. Continuous monitoring of patient's hemodynamic status is crucial. Now we have another example of abdominal pelvic fluid. Age 38, male, with no known allergies or chronic illnesses. Date and time are 10th January 2024, 3:45 p.m. Clinical indication: assessment for internal bleeding post-blunt trauma, blunt abdominal trauma. Patient presenting with pelvic discomfort and hypotension. These are the findings: right upper quadrant, no free fluid observed in Morrison's pouch. Left upper quadrant is also normal. Subphrenic space, both of them are normal. Pelvic view, the rectovesical pouch. Moderate fluid collection seen in the rectovesical pouch, indicative of possible intra-abdominal hemorrhage. Pericardial view is also normal. This is the impression: the presence of fluid in the rectovesical pouch suggests the possibility of intra-abdominal or pelvic bleeding. Absence of fluid in the right upper quadrant, left upper quadrant, and subphrenic spaces. Recommendations: given the ultrasound findings, the patient should be closely monitored for signs of hemodynamic instability. Additional imaging such as a CT scan is recommended for a more comprehensive assessment of potential internal injuries and to identify the source of bleeding. Surgical consultation may be necessary depending on the patient's clinical progression and further imaging results. Patient's blood pressure and heart rate should be continuously monitored. Blood transfusion may be considered if hemodynamic instability persists or worsens. Now we have a report for extended fast exam in which the lungs are also scanned. Here is a case of pneumothorax. Patient information: age 29, female, medical history of asthma. Date and time are 9th January 2024, 9:30 a.m. Clinical indication: evaluation for possible pneumothorax following a high-impact motor vehicle collision. Patient complaining of acute onset shortness of breath and chest pain. These are the findings: anterior chest wall, bilateral, right hemithorax, absence of lung sliding and B lines, presence of barcode sign in M mode, suggestive of pneumothorax. The barcode sign is seen in M mode in pneumothorax. Left hemithorax, normal lung sliding with visible B lines, no evidence of pneumothorax. Other views were all normal. This is the impression. The ultrasound findings indicate the presence of a pneumothorax in the right hemithorax, normal sonographic signs in the left hemithorax. Abdominal and pelvic regions do not show signs of free fluid, and no pericardial effusion is observed. Here are the recommendations. Immediate management of the right-sided pneumothorax is necessary, which may include needle decompression or chest tube placement, depending on its size and patient's clinical status. Further evaluation with a chest X-ray or CT scan is recommended for confirmation and to assess the extent of the pneumothorax. Continuous monitoring of respiratory status and vital signs is crucial. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.